On to our next session, we would like to introduce you to a very important section of our colorectal surgical unit and CDBWA. We have a registry, a website, nrcrc.org, how we function it and how we register patients in an online system to track them down. We would like to introduce you to our website, and for a short speech, I would like to invite Dr. Akil Azmi, Senior Resident of Colorectal Surgical Unit Ward.
May I have your attention? This is Dr. Amjad Siraj. मैं पर्सनल रिक्वेस्ट है मेरी कि आप अपने मोबाइल से ये जो नेक्स्ट स्लाइड आएगी उसकी तस्वीर खींच लें, इसलिए कि आप मुख्तलिफ ऑर्गेनाइजेशन से ये हमने कैंसर रजिस्ट्री बनाई है कोलोरेक्टल कैंसर की. जस्ट वन पिक्चर एंड देन यू आर ऑफ, यू नो. उसमें क्या है कि इसमें एक छोटा सा 1 मिनट डेमोन्स्ट्रेशन है, सिर्फ वो देख लेंगे आप. तो अभी हो ये रहा है कि सिर्फ हमारे अपने ही पेशेंट्स हम उसमें रजिस्टर कर पा रहे हैं. इट्स एन ओपन फोरम फॉर द इंटायर कंट्री. हर आदमी को अब ये अच्छा फोरम है कि सब जगह बहुत शहरों से लोग आए हुए हैं. इरफान आया हुआ है, पेशावर से, लाहौर से लोग आए हुए हैं. तो सबके लिए ये मैंने इसीलिए मैंने ये एजेंडा पे नहीं था, लेकिन मैंने जानबूझ के सिर्फ 1 मिनट की एक प्रेजेंटेशन ये देंगे, वो प्लीज़ गौर से सुने और तस्वीर खींच लें उसकी. उसमें पासवर्ड आएंगे, फिर वो याद रखना मुश्किल होते हैं.
Okay. Assalamu alaikum everyone. So I'm just going to demonstrate to you our website. This is nrcrc.org, as you can see. And what you have to do is you first have to send an email to that website, to the email down below, info.nrcrc@gmail.com, where we will give you an account, like we'll sign you up. So right now, Professor Amjad Siraj Memon is here. So I'm signing in through his account details. Sorry. So basically, once we sign in, you get this dashboard which gives you these basic statistics. And so what you have to do is, if you have a patient that you want to register, you go to this link here. It says register patient. Once you decide to register a patient, then you have all this biodata and all these other basic information, and then you keep going next. So for example, here we have a patient who I just put in, and so it gives you fields to fill regarding his chemo treatment and his superoperative findings. Also, there are CT, MRI findings you can put in. Then once the patient comes on follow-up, you can add in and edit this data so that you can, if there's a recurrence, then you can put that in as well. And you can easily edit this data. This is how you edit the patient information. And regarding the history, you can edit the history and the investigations. The good thing about the investigations is you can even upload pictures of the CT and the MRI so that you have like basically it comes up like this. So you can always access it at any time. And it's very easy to use. It's a very simple web-based application. You can use it on your phones as well. All you have to do is just log in, and then you can access this and then register the patient. Once you have a list of patients, then you can, this is like, let's say you have about 10 patients, so you have a list here. If you want to search for any particular patient, you can just add in their name, and then it will come up, and then you can edit, you can view their record, you can add any attachments. Let's say a new biopsy report has come, you can attach that. Let's say a patient has come on follow-up, you can add their visit as well. So it's a very simple website to use. I just request all of you to please take a picture of this, nrcrc.org, and also you need to send an email to this email address so that we can sign you up on your own record for your own account. Thank you.
Thank you, Dr. Akil.
Lectures and discussions by pioneers and experts of the field will surely go a long way to educate junior surgeons and refresh knowledge of the experienced ones. The COLOCON 2022 has focused on the aim to provide a forum to increase awareness regarding colorectal diseases in health professions and promotion of advanced laparoscopic surgery in Pakistan.
It's certainly important to be looking for cures to medical disorders, but it's equally important to conduct research on human health and well-being. So, scientific paper is a result of it. Ladies and gentlemen, we are heading towards the last session of COLOCON 2022, which is scientific paper presentation.
For conducting this interesting session, I would like to call upon Dr. Sayyida Sara Kazmi. She is a senior registrar working at Dow University of Health Sciences, Karachi, completed her MBBS in 2012 and her FCPS in 2021. She is interested in minimally invasive surgeries, especially in hernia and colorectal. Madam, please come on stage.
So I'm keeping this. Okay. Bismillahirrahmanirrahim. Assalamu alaikum and good afternoon, everyone. As she has already mentioned, this is our very last session of this wonderful conference, and this is scientific paper presentation, and for which I want to welcome the panel of experts one by one on this stage. First, I would like to welcome Professor Hussain Mehdi on the stage. He is Professor of Surgery and Principal of Jinnah Medical and Dental College. He is also Dean at Sohail University. Sir, please. Now I'll welcome Professor S.M. Abbas on the stage. He is an FCPS surgeon with an experience of more than 40 years, previously serving as an HOD surgery and allied and principal in KMDC Karachi, Dean Faculty of Medicine at University of Karachi, and under and postgraduate teacher, trainer, and assessor, CPSP, and other professional bodies. Presently, he is working as an HOD surgery and allied and chief of clinical and academic affairs at Hashmani's group of hospitals. Now, we'd like to welcome Professor Abdullah Muttaqi on the stage. He is an FCPS, FACS, and FRCS surgeon. He is Professor of Surgery, Secretary, Surgical Faculty, CPSP, Editor at Pakistan Journal of Surgery, ex-President of Society of Surgeons, Karachi, ex-Central Secretary of General Society of Surgeons of Pakistan, and Examiner and Supervisor at CPSP. My last panelist, I welcome Professor Tabish Chawla, who is an FRCS, FACS surgeon working as a full-time faculty in General Surgery Department at Aga Khan University, Karachi. He was the immediate past section head of general surgery. His clinical work involved full spectrum of general surgery with special interest in surgical gastrointestinal oncology. So welcome all of you. Okay, now I'm going to welcome Dr. Riaz Ahmad, who is going to present his first paper. He's from Peshawar and he's fellow in colorectal surgery.
Good afternoon. My name is Dr. Riaz Ahmad. I'm a fellow of colorectal surgery at Shaukat Khanum Hospital, Peshawar. I'm here to present the short-term outcomes of our laparoscopic colonic cancer surgery, which we performed during the last 1.5 years at our newly developed surgical setup. Anybody, please? Actually, I have to change the slides. So I have no conflict of interest to declare. Laparoscopy has been commonly used in the treatment of colon cancer surgery. However, it remains challenging to achieve the oncological outcomes equivalent to open surgery. Then after a long debate and controversy, it is now well established and documented that laparoscopic colonic cancer surgery results in better short-term outcomes with improved survival. Despite its proven benefits, still laparoscopic colonic cancer surgery is underutilized among surgeons, and a steep learning curve is one of the main factors of its limited adoption. So the objective of our study is that whether laparoscopic colonic cancer surgery is safe at a newly set up, and whether a new laparoscopic unit can be established with comparable outcomes to the rest of the world. A brief about epidemiology. At present, worldwide, colon cancer is the second deadly and fourth most commonly diagnosed cancer in the world. Nearly 2 million new cases and around 1 million deaths they were recorded till 2020. And incidence has been steadily rising worldwide, especially in the developing countries that are adopting the Western way of life. Obesity, red meat consumption, sedentary lifestyle, tobacco, alcohol, they are the main driving factors behind the growth of these tumors. However, due to recent advancement in the early screening and treatment option, the cancer-related mortality of this cancer, it has reduced in developed nations. In the next 20 years, China and USA, they will be having the highest estimated number of new cases. At present, colon cancer stands third in our country, following breast and lung cancer. Now, just like any other cancer, the earlier the diagnosis, the better the prognosis will be. Fortunately, colon cancer is a slowly growing tumor, and a benign polyp typically taking around 10 to 15 years to develop into a cancer. Though this cancer is increasing, but the potential for cure is known to increase when it is detected early. The overall 5-year prognosis is 64%. Excellent prognosis is seen if it is detected at a localized stage. The prognosis is 91% 5-year, and we see around 37% of the patient at this stage. If the cancer has spread to the surrounding tissues, the prognosis drops to 72%, and we see 36% of the patient at this stage. For distant metastasis, the prognosis is 14%, and we see around 22% of the patient at this stage. A slide about the brief treatment. Surgery is the only curative modality of localized resectable cancer. Currently, all the colonic cancer, they are treated with upfront surgery, whereas neoadjuvant systemic therapy is not yet the standard. The UK Foxtrot trial of introducing preoperative chemotherapy is on long-term follow-up. In stage 3 patients, the adjuvant chemotherapy is the standard, and the use of adjuvant chemotherapy in patients with stage 2 disease, it is recommended only in patients with high-risk features for recurrence. And only the choice of palliation is left if the patient is having metastatic disease. This is our main objective, to determine the short-term clinical and oncological outcomes of laparoscopic colonic cancer surgery at a new setup. So we prospectively collected the data through our hospital information system, which is basically a prospectively maintained database from which we undertook this study. So all biopsy-proven colonic cancers of either gender above 18 years of age with acceptable ECOG for elective surgery between April 2021 to August 2022, they were included in the study. The data was maintained on hospital information system, as we are a paperless hospital, and then the data was analyzed through SPSS. Now coming to our results, a total of 68 patients underwent surgery. The median age was 42 with a range of 27 to 85. There was male predominance. We operate across the breadth in terms of BMI, though it's very difficult to operate on overweight and obese patients, but we do have operated on 17 overweight and 2 obese patients. All of the patients, they are preoperatively assessed by anesthesia team, and then they are given an ASA score. Majority of the patients, they were having an ASA 2, whereas 7 patients of ASA 3 and 1 of ASA 4 were operated to. This is the demographic of the patient which we received. Shaukat and Peshawar, they received majority of the patients from KPK and Afghanistan. 2 patients of Pindi and Islamabad region were operated too. This is basically the pre-operative staging. Majority of the patients, they present at T3 stage, while some are having T4 disease. On the other side is the lymph node stage. In Pakistan, because of the lack of primary health care, so our patients, they tend to present at a much higher stage, what the internationally published data is. The mean lymph node yield was 19. Majority of the patients they had R0 resection, whereas 2 patients had R1 resection. One had right hemicolectomy and the other had panproctocolectomy. Our length of stay was 5.8 days. Our mean operative time was 249 minutes. Mortality at 30 days was 1. And at our unit, we do follow the patient for up to 90 days in terms of mortality, and that we do include in our analysis. So the 90 days mortality was 2 in number. Now coming to the procedures that were performed, majority of the tumors, they were found on the right side of the colon. So the commonly performed procedure was right hemicolectomy followed by sigmoid colectomy. Extended right hemicolectomy was performed for the tumors in the proximal transverse colon and hepatic flexure. 3 patients had panproctocolectomy because they were having synchronous tumor in the rectum and ascending colon with multiple polyps throughout the colon. Now coming to a complication, as you can see, less frequent complications they are seen in our study. 5 patients have SSI, and this is because we do operate laparoscopically. 8 patients, they were shifted to ICU for less than 24 hours, and this is for the monitoring purposes of their comorbidities. 1 patient was converted to open, and this is purely because the patient was having locally advanced sigmoid colon cancer, and there was bleeding during splenic flexure mobilization. So we thought it will be good to to open the patient to control the bleed. 1 patient we have to re-explore during the same admission, and that patient had panproctocolectomy. On the first postoperative day, the patient developed pelvic hematoma, and we have to explore for the pelvic washout. About the mortality, if I go into the details, 1 patient had aspiration followed by respiratory failure, and the patient died after 3 weeks. The other patient went home, started chemotherapy, and then had chemotherapy-related mortality. But as that mortality was within 90 days, so we have included that in our study. Luckily, we have no anastomotic leak during the time period of our study, but unfortunately, we have seen 2 leaks in the last 2 months. This is the post-operative histology. As you can see, majority of the patient, again, they are having a T3 disease, which is consistent with our preoperative staging. And it also shows that our preoperative staging is fairly accurate. We not only operate on the early disease, as you can see in this picture, the small bowel is adherent to the locally advanced cecal cancer, and we have to go for right hemicolectomy with in-block resection of the small bowel. This is a picture of locally advanced transverse colon cancer involving the greater curvature of the stomach, and we have to go for extended right hemicolectomy with partial gastrectomy. So in conclusion, ladies and gentlemen, laparoscopic colon cancer surgery is performed at a high volume center by trained and experienced subspecialized surgeons, then is safe even in a newly established unit. And our short-term outcomes, they are consistent with those published in the literature. So in the end, I would like to thank my head of department, Sayyid Irfan Kabir, and my both supervisors, Dr. Muhammad Fahad Shah and Dr. Irfan Islam Nasir, for helping me out, for all the guidance, for advices. I'm grateful to them, and thank you.
Sir, for the question, any question regarding that one?
I have a question.
Okay, sir.
Very nice presentation, and it's a very nice thing to see that new unit has been opened and you're doing good.
Sir.
I was surprised at one of your slides where it showed that you had the majority of your patients were right-sided tumors.
Yes, sir.
Now, we have quite a large volume of cancer in our unit.
Sir.
Up until 2019, the last COLOCON, that the conference that we held, we were doing 135 to 150 cases a year. So the summative, total in that conference was some 8 to 850 patients, and it's quite a big volume. We are seeing more left-sided cancers now, and we hardly, out of 100, maybe 2 or 3 cases would be right-sided. I am surprised that maybe in the upper part of the country, they still are having right-sided tumors. I don't know, Dr. Najib, would you agree that with my notion?
Yes, I do agree. The other thing is most of their tumors, they are also node negative. 35 or 38% are node negative.
Yes,
so
sir.
probably these are, have you done MSI studies on these stage 2 patients to see whether they are Lynch syndrome patients or not? Any idea?
Of course, sir, we do, like at Shaukat Khanum, we do operate on locally advanced, but majority of the tumors, they are early tumors. And as sir has said, that the upper part of country, like the Malakan and Swat and their division, we got majority of the tumors on the right side of the colon. And still, like even in the coming 2 weeks, we have to operate a few more colon cancers, which are involving the right side of the colon. So we are getting the right side more common as compared to the left side.
Assalamu alaikum. I would like to add further to what Dr. Riaz has said. So yes, so from the upper part of the country, we have got a lot more right-sided tumors as compared to the left-sided. But then again, it's a colon cancer, and normally the primary physician or the surgeon to whom they present initially, they don't leave actually right-sided tumors as well, as very rightly mentioned. So to whomever they present, they normally like to carry on with it. And the second part of the question, that MSI testing. So normally we offer MSI testing to all of our colon cancer patients, and according to the results, then the oncologists decide whether they would need further chemotherapy or not. Thank you.
Thank you.
Okay, for the second paper, I will call Dr. Dileep Kumar and Dr. Rabbiya Ali from Karachi. Dr. Dileep Kumar is an FCPS MRCS consultant general and laparoscopic surgeon. He is working currently as a research associate in CDPWA. He worked as an associate professor at Ziauddin University Hospital and JMDC. He has published multiple research articles and case reports in national and international journals. Dr. Rabbiya Ali is an FCPS MRCS surgeon who is consultant at Department of General Surgery Unit 6 at Dow University of Health Sciences, Karachi. Please, both of you can come on the stage. Okay, from over there.
Yes.
Okay.
Hello everyone, my name is Dr. Dileep Kumar. Today I am going to present my topic on the role of neoadjuvant chemoradiotherapy on the signet ring cell adenocarcinoma. And
Can you please show the slides?
I am really sorry that I could not face the audience and the screen at the same time because of my disability. I am presenting from here.
Yes, please show the slides. Yes, I gave.
Slides.
Start.
So the topic is to assess the role of neoadjuvant chemoradiotherapy on signet ring adenocarcinoma of rectum. Next. So briefly, I am introducing what are the signet ring cells. Basically, these are the cells which have intracytoplasmic mucin, and these are the group of some neoplasms which have very high aggressive behavior, and they do not respond to chemotherapy overall. And if there is a presence of intracytoplasmic mucin, we label it as a signet ring cell. And if there is an extracellular extracellular mucin, we label it as a mucin. And And those cells which have both the components, we label it as a mixed mucinous and signet ring cells. The literature, previous slide. The literature is somehow the the signet ring cells is more prevalent in the Indian subcontinent region with overall 13% prevalence rate as compared to 1% in the Western population. And in Western population, the left-sided signet ring cells are more common as compared to the Indian subcontinent Pakistani region, where the left and right-sided both the signet ring cells are present. Because of the younger age at presentation and the greater propensity of the peritoneal metastasis and frequency of nodal involvement, and it carry a very worse prognosis. Next. So what is the appropriate approved strategy to encounter these cells? Normally what we do is we definitely do the neoadjuvant chemotherapy to shrink the tumor size in the rectum, so that we get the cuff of at least 2 to 3 centimeter of tissue, so that a low anterior resection or sphincter saving surgery is performed. So the strategy is initially, if the tumor is obstructing, we used to do the divergent stoma and then do the neoadjuvant chemotherapy to shrink the tumor size, to perform the sphincter saving surgery or definitive surgery, and after that, if feasible, then adjuvant therapy and the reversal of the stoma. Next. So most of the literature evaluating the effectiveness of neoadjuvant therapy assess all the local advanced rectal carcinomas altogether. However, the signet ring cells behave differently from the conveniently encountered adenocarcinomas. Hence, these result trials cannot be generalized. And our study is retrospective view, and we want to investigate whether there is any role of neoadjuvant therapy only for the signet ring cell or mucinous carcinomas. So ethical review board has been taken into confidence. Next. So overall 220 patients were admitted in colorectal ward, and out of which 182 were having the general conventional adenocarcinomas, and 38 patients were belonging to mucinous or signet ring cell carcinomas, out of which 2 patients were metastatic and that were excluded, and the 15 patients who are mostly on the right-sided are rectosigmoid tumor, and that has been excluded. So only 21 patients are fit to be included in our study. The staging is done by the natural convenient methods like CT scan, MRI of the pelvis, and colonoscopy, biopsy, and all these tumors were presented in the multidisciplinary meeting and tumor board meeting before referred to the oncologist. Next. So the primary outcome of this study was the T-stage assessment, how much the tumor has been shrunken from the T3 to T2 or T4 to T3 stage. So after the neoadjuvant chemotherapy, the patients were re-evaluated, restaged by the CT scan or MRI pelvis. So the record has been inserted into the SPSS version 22, and then the results were obtained using the various tests. Next. So the mean age in our study was 37 years, that is very quite young years as compared to the international research data that shows the mean age is 57 to 60 years. 13 patients were the male and 88% were the female, and in histological subtype 16 patients belonging to signet ring cell and 2 patients belonging to mucinous and 3 patients having both the components of signet ring and mucinous. Regarding the cellular differentiation, 20 patients were poorly differentiated and all these patients were signet ring cells. Only the 1 patient who was moderately differentiated, that was the mucinous carcinoma. And and there's a partial, there's only the 14 patients were the partially obstructed, and while the 6 patients were completely obstructed. The involvement of the mesorectal fascia were in the 17 patients. So before neoadjuvant therapy, the 5 patients were belonging to the T3 group, and out of these 5 patients, the 4 patients progressed to the T4 after neoadjuvant therapy, while the 1 patient remained in the T3 stage. And in T4, 16 patients were in the T4 group, and after neoadjuvant, 20 patients that were progressed from T3 to T4. And none of the T4 patients were regressed to, and there's no change in it. The p-value is 0.238. That is quite high, and that shows there's no difference in the neoadjuvant chemotherapy. So this is the graphical presentation. Next. So the discussion will be done by given by the Dr. Rabbiya.
Thank you, Dr. Dileep. So the discussion of our study is that the clinical experience is directed to evaluate the efficacy of neoadjuvant therapy in the treatment of SCRCs. And as evident from the study, neoadjuvant therapy is a standard of care, but it failed to produce satisfactory results in our study. So the finding of the study is to depict the treatment resistance and violent nature of the signet ring cell tumors, those reported elsewhere. Neoadjuvant treatment considerably improved outcome in trials involving locally advanced rectal cancers. However, it was not apparent from our study. This difference can be attributed to the fact that our study only included signet ring cell tumors, and it has not received sufficient representation in other trials yet. So we left metastatic tumors. A point to be noted is that the mean age of the patient in our study is 37 years. But so far, the least age group I saw in study is the 13-year-old guy in our study. While the prevalence of signet ring cell tumors in cohort was higher, that is 13.7%, than the 1% reported in the literature, it is nevertheless equivalent to that of the developing world, notably to the Indian subcontinent. So neoadjuvant therapy is a component of the standard practice used for locally advanced tumors, and it has shown promising results in the treatment of adenocarcinoma of the rectum by downstaging the tumor, followed by surgical exploration. However, these benefits are largely observed with common conventional adenocarcinomas. So the signet ring cell needs more attention exclusively because it is a rare tumor. One trial comparing the choice of neoadjuvant therapy illustrated that no matter what type of neoadjuvant strategy was employed, the prognosis of signet ring cell tumor remained poor, as shown by dismal disease-free survival of 18 months and half of the patients dying of the illness in 3 years. None of the patients from our cohort benefited from the neoadjuvant therapy. Instead, due to the time consumed during its administration, the tumor advanced to a higher grade following its natural course. This is demonstrated by the fact that the 4 patients in the cohort with T3 group stage up to the T4 after 6 months after neoadjuvant treatment trial. So the conclusion of our study is that CRCs, signet ring cell tumors, do not respond to neoadjuvant therapy, as tumor regression was not seen in any of the subjects. We suggest that such aggressive and resistant cancers as signet ring cells should undergo definitive surgical treatment without neoadjuvant therapy so that tumor progression and distant mets could be prevented. Lastly, we believe that treatment protocols should be individualized for this rare histologic subtype of rectal cancer. We have certain limitations. Firstly, it was a retrospective cohort study, so we couldn't do a clinical trial. And so, as it is a rare type of tumor and patient presentation in OPD is lesser than the rest of the adenocarcinomas, So it needs further prospective trials in order to make a guideline about surgery or neoadjuvant. Any questions, please?
Can I answer the question?
Yes, sir.
Can I have the mic? Yes. I'll be ready to answer any questions, but before I go to the question part, when my team was going to present this, they asked me that this is a controversial topic and what we are suggesting is totally against the parameters that are established कि आप सबका जो है इन rectal cancers का neoadjuvant treatment ज़रूर कराया करें. The results are in front of you. 21 patients, 38 थे जिसमें से fit for surgery 21 निकले. उन 21 में से 20 had no effect. None whatsoever. In fact, जो हमारे पास neoadjuvant के जो तरीक़ाकार हैं, if you go into the details, the patient comes back to us, although the NCCN guidelines कहती हैं कि 5 to 12 weeks आप wait करें surgery के लिए, लेकिन जो हमारे surgical crowd है internationally and nationally, most of the crowd waits more than 8 weeks, and हम Professor Amjad चीमा की टीम के साथ हमारा ख्याल ये था कि हमें 12 वीक्स तक उसका फुल फ़ायदा जो लॉन्ग कोर्स दिया उसका मिलना चाहिए मरीज़ को. तो एट 12 वीक्स जब हमारे पास पेशेंट वापस आता है तो इट्स ऑलरेडी टू एडवांस्ड इवन टू डू एनीथिंग. एंड आई टेल यू फ्रॉम a lot of experience now that it's a very difficult death to die of a locally advanced rectal cancer. It's such a miserable life. We do give them a stoma to avoid obstruction, but the life that they have is so painful that हमारे पास जाहिर सी बात है उसके अलावा heavy pain killers हम दे देते हैं, लेकिन मैं जो suggest नहीं कर रहा हूँ, मैं ये कह रहा हूँ कि कोई हमें ज़्यादा ट्रायल्स की ज़रूरत पड़ेगी at a national level or maybe at an international level as well before we say to the crowd कि look, here the neoadjuvant is not working, upfront surgery, और जो बेहतर ऑप्शन मुझे लगता है कि शॉर्ट कोर्स दे दो और फारिग करो.
Right.
मैं यहाँ पे दो बड़े बड़े ऑन्कोलॉजिस्ट मेरे बराबर में बैठे हैं, तो डॉक्टर नदीम अब्बासी, व्हाट डू यू थिंक?
अच्छा देखिए, सबसे पहले फर्स्ट ऑफ ऑल योर प्रोफेशनलिज्म एंड एथिक्स. तो आई थिंक इट इज़ ग्रेट टू ब्रिंग कंट्रोवर्शियल इशू. दैट इज़ वाई द कॉन्फ्रेंसेज आर देयर. ये कोई क्लासरूम तो नहीं है ना. This is not a tutorial thing. I think excellent. Thank you very much for bringing it forward, and I congratulate your team, and especially Dileep and yourself. Number one. Number two, एक मैं बड़ा क्लियर कर दूँ आपको, being a student of radiation oncology, कई जगहों पे आप लोग being surgeons ये समझ रहे हैं कि इस पेशेंट की रेडिएशन हो गई है. अनफॉर्चुनेटली नहीं हुई है उसकी. क्या आप में से कितने लोग वाउच करेंगे इसको कि जब आप ओपन करते हैं तो किसी में तो सिवियर फाइब्रोसिस मिलता है, किसी में लगता है कि ये बेचारा शायद वहाँ वैसे होके आ गया बाहर से. तो ये क्यों हो रहा है? दूसरी बात है ईद के गैप्स, बकरीद के गैप्स, आशूरा के गैप्स. तो जब हम वर्ड यूज़ करते हैं ना, इस पेशेंट की रेडिएशन हो गई है, तो कहीं ये मफरूज़ा ना हो, हुई नहीं है उसकी, और आप एक्सपेक्ट कर रहे हैं कि जी वो आप इंटरनेशनल स्टैंडर्ड का आपको रिजल्ट मिल जाए. आधा सिंध प्रोविंस हमारा जो है वो कोबाल्ट पे ट्रीट हो रहा है, जो कि इट्स ए क्राइम. इट शुड नॉट बी ट्रीटेड एक्चुअली. ना करें, बेहतर है ना ट्रीट करें, फिर आप ऑपरेट कर लिया करें पहले उसको. तो पहला पॉइंट नंबर 1. पॉइंट नंबर 2 बड़ा इंपॉर्टेंट ये कि ये डेटा जो है इसका जो स्ट्रेंथ है वो 220 आपका डिनोमिनेटर है, वो बहुत स्ट्रॉन्ग है. वो डिनोमिनेटर हमें बता रहा है कि एक्चुअली वी आर प्रैक्टिसिंग विद ग्रेट फ्रीक्वेंसी, लेकिन हमारे पास कुछ इक्वेशन लैक कर रही है इधर. तो तीनों को अच्छा होना पड़ेगा, कोलोरेक्टल सर्जन को भी, रेडिएशन ऑन्कोलॉजी हाई क्वालिटी की, और नंबर 3 पे जो हमारे भाई बैठे हुए आपने कहा ना बड़े ऑन्कोलॉजी, वो इनको कह रहे थे आप, नजीब मुझे नहीं कह रहे थे. अब इनकी जो कीमो के मसाइल हैं वो भी तो देखने होंगे ना, फ्रीक्वेंसी, टाइमिंग, ये मैं इनको टारगेट नहीं कर रहा, मैं बता रहा हूँ आपको कि उसमें भी बहुत सारी चीज़ें हमें देखनी है, कॉकटेल्स के अंदर भी. तो तीनों इक्वेशन के बाद एमडीटी से मसला हल होना है. ये बड़ी बात है कि आप माशाल्लाह बीइंग ए सर्जन इसको ला के और पूरा ब्लेम अपने ऊपर ले रहे हैं, आप इस तरह ना लें. तो आई थिंक सिग्नेटिंग डिफिकल्ट है, हमारा भी, ये सारी दुनिया का है, तो कोई चीज़ इसमें ऐसी नहीं. और नल हाइपोथेसिस आपने देखा 0.2 हमारा 2-3 आ रही है पी वैल्यू. तो आई थिंक वी शुड कंटिन्यू ऑन दैट. लेकिन इस डाटा को ना एक दफ़ा न्यूट्रल पैनल को बैठ के देखना ज़रूरी है. आई विल बी वेरी हैप्पी एज ए स्टूडेंट कि मैं उसमें रेडिएशन ऑन्कोलॉजी का आपका देख लेता हूँ. आपको जो है ना ये जो ईद की 9 दिन की छुट्टियाँ रेडिएशन के बीच में जो आ रही हैं पूरे पाकिस्तान में और बकरीद की छुट्टियाँ, इसके बाद आप वो एक्सपेक्ट करें अगर रिजल्ट्स, तो वो सॉरी टू से दैट. और मैंने काफ़ी हमारे सर्जिकल कोलीग बैठे हुए हैं, प्रोफेसर हारिस मेरे क्लास फेलो भी हैं, काफ़ी दफ़ा बात होती है. वो मतलब जब वो आप खोल रहे हैं तो आपको इतना वेरिंग डिग्री क्यों मिल रही है फाइब्रोसिस की. अच्छा, अब आते हैं आपका आखिरी सवाल जिसमें मैं सॉरी फॉर टेकिंग लॉन्ग. शॉर्ट और लॉन्ग कोर्स में देखिए पूरा यूरोप शॉर्ट कोर्स कर रहा है भाई. आप ज़रा इसको मेरी बात को येस या नो करें, अगर नहीं करें तो आप बता दें मुझे. तो फिर अब आगे आप लोग बात करें अपनी. तो मेरा ख्याल है ये मल्टी डिसिप्लिनरी मसला हल होगा, सिर्फ सर्जन से नहीं होगा, सिर्फ रेडिएशन वाले से नहीं होगा, सिर्फ कीमो से नहीं होगा. तो हमारे रज़ा भाई की जो बात है वो हमें लोअर जीआई की ना एक सिटी लेवल पे बनानी पड़ेगी, एमडीटी ट्यूमर बोर्ड, वरना हम हर साल माशाल्लाह आप करते हैं और हमेशा डिबेट आगे ही जा रही है. इट्स ए गुड न्यूज़ एंड आई थैंक यू ऑन बिहाफ ऑफ द पेशेंट्स एक्चुअली. तो आई फिनिश हियर, सॉरी फॉर टेकिंग लॉन्ग. डॉक्टर नजीब को, अच्छा इनको मैंने कोई बुरा भला नहीं कहा, बड़े मेरे, मुझसे बड़े मैं इनकी बड़ी इज्जत करता हूँ. सफ़ेद दाढ़ी है इनकी भाई.
अच्छा, दाढ़ी के बालों पे मत जाइए, सर के बालों पे जाइए. एक्चुअली मैं बड़ा नहीं हूँ, इन दोनों से छोटा हूँ. ओके, अच्छा बात तो सही है. मीन्स वी डोंट हैव अ डेटा ऑन सिग्नेटिंग कार्सिनोमा एंड इट्स अ पुअर हिस्टोलॉजी विद अ पुअर प्रोग्नोसिस. चाहिए हमें क्या, हमें चाहिए उसके मॉलिकुलर सिग्निफिकेंस के भाई क्या होता है उसके अंदर. वी आर लैकिंग ऑन दैट. वी ट्रीट ऑल rectal cancer stage 2 and beyond, locally advanced localized cancer with total neoadjuvant therapy now, concurrent chemo radiation or short course radiation, chemotherapy and then surgery. Previously we used to give only chemotherapy, only radiation or concurrent chemo radiation followed by surgery and then chemo. The advantage of chemotherapy, giving chemotherapy before, is that we can see whether the patient is responding to chemo or not. So if we have that data after 3 cycles of chemotherapy, if we repeat the CT scan and see that the patient is progressing on chemotherapy, we don't have to give further chemo. In adjuvant setting, we have to give the full 6 months of chemo. So that's the advantage of giving chemotherapy before surgery. Number one, we can see the response. Number two, I agree that short course, अच्छी चीज़ है. We can try short course in a short tumors, not long tumors, I think. And then we can try surgery. But upfront surgery, I'll be a little bit reluctant. The reason is if you do upfront surgery before chemo or radiation, then we'll have more side effects because the bowel will come down. Dr. Nadeem Abbasi will correct me if I'm wrong. And then the patient can develop more gut side effects.
And less oxygen. And less oxygen. So more side effects of radiotherapy post-operatively. Because it's all diathermy और सब हो चुका होगा वहाँ. Sorry, आप continue.
So upfront surgery will be difficult, I believe. It's better to give chemo, not full chemo, 2 or 3 cycles of chemotherapy, see the response, the patient is responding, continue with chemo. If not responding, go for short course radiation followed by surgery. What do you think?
Can a surgeon speak now?
Yes, absolutely.
Professor Amjad Miman, excellent observation and a very sensitive one. And this is what we have discussed in another conference, and the surgeons are observing that. And this brings us to the point raised by On Jamil, that our patients have different tumor biology. And we need to, and I agree with you, I published this in 2015. My paper's limitation was of a smaller sample size, and this brings us to your suggestion. We need a multidisciplinary prospective trial in a trial setting to establish that what kind of patients we are dealing with. The observation by many surgeons in town, and I'm sure up country also, that our patients of rectal cancer usually are not responding the way, and this includes signet cells and non-signet cells, the way we read in Western literature. But this will still remain an observation unless we have a good, robust trial.
Okay. I would like to acknowledge 2 third-year medical graduates, Afira and Azam. Please stand up. They made a team with Dr. Dileep to compile this manuscript. So please have a big round of applause for them. They really did hard work along with Dr. Dileep. Thank you.
Okay, now I will call Dr. Azhar from Lahore. He is consultant surgical oncologist at Services Hospital, Lahore.
Assalamu alaikum everyone. I am Dr. Azhar Alam, Senior Registrar Surgery at Lahore General Hospital, Lahore. I am here to present my data of surgical and colorectal surgery in the Department of Surgery at Lahore General Hospital, Lahore. I am here to share my experience of establishing oncological services at public sector hospitals in Lahore. Up till now, when I am talking to you people, up till now there is no dedicated unit at public sector hospitals in Lahore. We start our journey from 2017 to establish a unit in a Department of Surgery at Lahore General Hospital. The services consist of upper GI, lower GI, and hepatobiliary surgeries and breast surgery. Yes. I'm here to share the colorectal experience. Our setup consists of 60-bedded unit and with 6 elective operation rooms and 2 emergency operation rooms with 3 laparoscopes, 1 in emergency and 2 in elective settings. And there is a established pathology unit and radiology unit and MRI unit. There's 3 Tesla MRI which is there. But no oncological services available at our hospital. This is our surgical equipment, and this is our overall settings, and we are equipped with that circular staples and the linear staples and all those stuff. Colorectal surgery, all cases, I want to share my experience that all cases from January 2017 to December 2021, all these cases are included in this our study. Patient demographic area and presentation through emergency or elective, and type of surgery which we done, complication, adjuvant and neoadjuvant therapies we had done, all will be shared in this presentation. Yes. When we started in 2017, there was 12 patients registered. It was low volume. And 2018, there were 23 cases. In 2019, there were 33 cases. In 2020, there were 37 cases. And 221 and 50 cases done by our team. Out of them, 30 cases were operated in emergency department and 125 were as elective settings. Okay. Out of which 80 were done by laparoscope and 75 open surgeries was done. 5 were converted into laparoscopic were converted into open surgeries. Okay. Our data elaborates that 3 re-exploration were done and post-operative 1 death was documented. Only 32, one thing which I want to focus that 32 cases were discussed in our hospital tumor board. Due to certain limitations in the next coming slides, I will explain that what was the things, what were the ground realities which we have to fight while establishing a cancer registry, a cancer unit at public sector hospital. Our case mix is colonic cancer are 71 and rectal cancer are 84. Out of colon cancer, there were 35 were laparoscopic and 36 were that open cases. This does not show that we don't have laparoscopic unit. This shows the advanced disease, the other factors are there. In laparoscopic, in various surgeries we have done, there are sigmoid colectomies, various right hemicolectomy, left hemicolectomy, total colectomy. These are various figures over here. Sigmoid colectomy we have done 31 resections, right hemicolectomy we have done 22 resections. Okay. These are rectal cancers. This is breakup of laparoscopic we have done 45 and open we have done 39 cases. This is one thing more. Emergency cases, there are 7 emergency cases of rectal cancer, and elective there was 77 cases, out of which the break is that anterior section is 15, Hartman procedure is 16, and APR is 21, extraluminary APR is 8. These are the various breakup of our cases of rectal cancers. Type of surgeries, this is the brief summary of the previous slides. These are the various specimens for anterior resections and the sigmoid colectomy as shown here. This is another case of laparoscopic anterior resection with covering ileostomy. These are the on right side there are other samples. This is the laparoscopic right hemicolectomy, and the patient's his picture is also there. Laparoscopic scar is minimum. This is another case. These are 2 cases. One is done in elective settings, total colectomy for the synchronous tumors, and these are the obstructing on right side there is the obstructing tumor presented in emergency. We have done total colectomy. These are the lap pan proctocolectomy for FAP, and with covering ileostomy we have done ileal pouch, anal anastomosis. This is locally advanced cancers involving the vagina and the cervix, and we have done posterior exenteration, pelvic exenteration. And one other case is tumor of cecum involving the anterior abdominal wall. This is the extra-elevator APR settings, which were nicely explained yesterday by Dr. Jamal, and this is some glimpse. We do it in a prone position, jackknife position. These are the samples of the extra-elevator APRs. This is the pelvic floor reconstruction with omentum or sometimes omentum and mesh. This is the specimen extraction. Pathological outcome were median lymph node removed were 13, proximal margin all were negative, distal margin involved in one case of CA rectum, CRM were positive in 4 patients of CA rectum. Complication, this is our share of complication: 1 post-operative death due to sepsis and bleeding, and 1 anterior resection re-explored due to the bleeding, and the 1 sigmoid colectomy due to leak. We have to reopen. 18 patients were wound infection were there. Follow-up, median follow-up was 19 months in this study. More than half of the patients have been lost to follow-up. This is our problem. 4 distant presented with the distant relapse. There our problems which we have to face to establish an oncological services at public sector hospital. These were pathology and radiology services related problems जो कि communication errors के issues हैं, reporting का standard format नहीं है जिसके लिए हमें we have to communicate with them, and with times things have been improved. Oncology, there is no oncology unit at our setup. We have to communicate with the Anmol hospital for this, and now the things have been improved. But up till now there is no MDT, मतलब weekly MDT नहीं है हमारे पास. We have only monthly MDT services, which is lag behind. Okay, one more problem is the patient follow-up. Once the patient, जैसे कि अभी डिस्कस हो रहा था सुबह कि पेशेंट फॉलोअप के लिए जो हम उसको रखते हैं तो वो फॉलोअप लास्ट हो जाता है. हमारे साथ ये प्रैक्टिकली हुआ है कि पेशेंट लास्ट टू फॉलोअप हो गया. मोर देन 50% पेशेंट जो है हमारे वो अबाउट लास्ट टू फॉलोअप हो गए. लेकिन अब हमारी कोऑर्डिनेशन जो है इम्प्रूविंग है और इससे चीज़ें बहुत इम्प्रूव हो रही हैं. वन थिंग मोर इम्पॉर्टेंट जो जिसकी तरफ मैं आपको बताना चाह रहा हूँ कि व्हाट इज़ द हाई वॉल्यूम सेंटर, जो कि रिकमेंडेशंस हैं. ये इसमें इस स्टडी में देरी स्टडी के हाई वॉल्यूम सेंटर जो है इट इम्प्रूव्स द आउटकम ऑफ द कोलोरेक्टल कैंसर्स. मूविंग फ्राम इसमें देर इज़ नो येट कंसेंसस बट देर इज़ a range of 10 to 60 major resections per year. It shows the major high volume center, but our outcome is that 2017 we have done 12 cases, in 2018 23 cases, 19 33 cases, and 2020 37 cases, and 21 50 cases. I put this question to the my panelists and all for this: are we yet there or not in a public sector hospital? Especially, are these numbers enough to train someone? Yes. Conclusion of my study is that a dedicated colorectal facility can be established in a public sector hospital. It is not a thing जो कि हो नहीं सकती. It can be done. We have done it on ground, alhamdulillah. And these services not only give better outcome but also train the surgeons for future colorectal surgeons. Every hospital should be running dedicated colorectal services in the best interest of patients and the training of the surgeons. All facilities under one roof, yet I think there is no in the public sector hospital, but it should be under the one roof. Especially oncology हमारे one roof में नहीं है. We hope that our center will be recognized for training, inshallah. Any question? Thank you so much. Thank you.
Thank you. Now I will call Dr. Abdul Rahman from Shaukat Khanum Memorial Hospital, Lahore. He did his fellowship in general surgery in 2020 and fellowship in surgical oncology in 2022. Dr. Abdul Rahman. He didn't come. Okay. Sorry for the inconvenience. I will call another person right now. I'm calling Dr. Hina Khan from Dow University Hospital, Karachi. She has an FCPS and FACS. She is consultant general surgeon with special interest in colorectal surgery. She is currently working as an assistant professor in Surgical Unit 5. She is an active member of CDPWA. आप लगा दीजिए प्रेजेंटेशन लगा रहे हैं.
Bismillahirrahmanirrahim. Assalamu alaikum. Today I am going to discuss about the early onset colorectal cancer. Next. So these are the authors of my study, and there is no conflict of interest regarding the presentation. As far as the global burden is concerned for the early onset cancer, it is, and the colorectal cancer is the third commonest cancer all over the world. Majority of the cases are present in the rectum, followed by the left colon. This is the local data from the Shaukat Khanum Hospital, Lahore, which is suggesting that the colorectal cancer is the second commonest colorectal cancer among the 10 malignancies. So the colorectal cancer is divided nowadays in two categories, that is the early onset and the late onset colorectal cancer. Any cancer that is developing before the age of 50 years is called the early onset cancer, which accounts about 10% of the cases. And usually it affects the rectum and the left side of the colon. In one of the study, it is stated that by the end of 2030, there will be 11% of the colonic and 23% of the rectal cancer will occur in the US in young adults. And it has a worse prognosis because it is diagnosed in the delayed as an advanced disease. So these are the different risk factors in these kind of patients, like the Caucasian ethnicity, obesity, hyperlipidemia, male gender, alcohol intake, and the history of colorectal cancer in the first degree relative, sedentary lifestyle, ulcerative colitis, and the hypertension. These are the different factors which can lead to the bad prognosis in the early onset colorectal cancer, like if the microsatellite instability is present, and if there is a family history of colorectal cancer, and these patients are usually present on the left-sided colorectal cancer. Their disease is usually advanced at the time of presentation, and usually the time from the symptoms till the diagnosis is very long. And for the pathology, in these type of patients, the mucinous and the signet variety is very much common. So the objective of my study is that to find out the prevalence of early onset of colorectal cancer, and the rationale was to find out the burden of this disease in the early age group, so that we can standardize the screening program at the national level. It was a retrospective cohort study done at Surgical Unit 1, Civil Hospital, Karachi, from 2018 August to July 2022. We retrieved the data from our national registry software, which was developed by our unit in 2019, and it is web-based software. The statistical analysis was done by the SPSS version 21. So these are the results. There were about 176 patients of early onset colorectal cancer. Among them, 105 were males and 71 were females. The mean age was 30 years, and the range was between 16 to 50 years. Majority of the patients presented with the adenocarcinoma, and a large number were, these are the numbers of signet variety. 36 were of signet variety, and the 24 were the mucinous. And the rest of these tumors were labeled as just the adenocarcinoma. And there were about 8 patients of squamous cell carcinoma, and 3 of neuroendocrine, and 1 lymphoma. Majority of the patients were of the rectal and the rectosigmoid junction. As we have discussed earlier as well, that majority of our patients are in the advanced stage, that is T3 and T4. Whenever we operate, usually we get these type of findings in these patients. This is the advanced disease. And these are the pictures of signet variety adenocarcinomas. So the majority of the patients were of poor socioeconomic status. And these are the breakup of the surgeries which we perform. And the large quantity was the divergent stoma because majority were of advanced stage. So on follow-up, we found that the 16 patients lost the follow-up, and there were 6 patients who expired. 4 were presented with the recurrence, 2 with the hepatic recurrence, and 1 patient with the liver and the peritoneal metastasis, and other one was with the liver and the lung metastasis. So there are multiple studies which has been suggested that now the early onset colorectal cancer is increasing, its incidence is increasing, so the education at the public level is very much important so that we can educate them about their lifestyle modification, and to advise the young patient to be vigilant for the follow-up and to present with the symptoms, those alarming features earlier as compared to the delayed presentation. We should, so I want to conclude that the colorectal cancer in the young group is of early onset, but it is diagnosed very late. So the awareness should be done for the early detection. We should do the major work on the research so that we can identify the quality of life among these type of patients and the surgical outcome properly, and we can form the guidelines for the screening in the young patients. And these are the different challenges which are faced during the management of these early young patients, like the fertility, pregnancy, sexual health, and the financial issues, and the long-term survivorship. Thank you. Any questions?
In the last, I will welcome Dr. Rubab Nafees from Karachi. He is an FCPS surgeon working as consultant in CDPWR on an honorary basis. He has special interest in colorectal surgery and surgical oncology. He has published 9 articles and 3 case reports in international journals. Assalamu alaikum and good afternoon, everyone. I'm Dr. Rubab Nafees, and I'm going to present my paper, Factors Affecting Delay in Colorectal Cancer, a cross-sectional study from a tertiary care hospital of Karachi, Pakistan. The need of this study was because we were receiving patients at an advanced stage, the late presentation in a tertiary care hospital. The patient was not referred from the general physician on the time. The primary objective of this study was to determine the cause of delay in CRC, and the secondary objective was to evaluate the tumor size and site and stage of the CRC with the presenting symptoms and symptom duration. The colorectal cancer is the second most common cancer in Pakistan, and because of due to the lack of the cancer data registry in Pakistan. The patient we receive usually are at Duke stage C, while the rest of the world is receiving these CRC patients at Duke stage A or B, that is much easier to treat, either surgical or neoadjuvant therapy. So we differentiate the patient in 3 types, like the patient who got laid on their own end because of the lack of the knowledge. Either they are thinking that these are familial hemorrhoidal bleeding or something else. or the patient, the second one is on the physician delay, that is the diagnostic delay. When the patient reaches a general physician after the onset of symptoms within 3 months, but the physician delayed it for more than a month for the diagnostic investigations like either colonoscopy and CT scan, that is the diagnostic delay. The treatment delay is when the patient is diagnosed on time, but the patient did not receive any neoadjuvant therapy or surgery within 3 months of the diagnosis. This is the treatment delay. Most of the time, the general physician thinks that there is a resemblance of the symptoms of the CRC is either with intestinal TB or IBD, and for the right-sided colonic cancer. While in the left-sided colonic cancer and rectal cancers, they think that these bleedings are because of the hemorrhoid, fistula, and fissure. We also receive the patient. We also receive the patient more from the underprivileged area, those are from the low socioeconomic group, and more than the 2/3 of the patients belong to the low socioeconomic group. And the material and methods. The patient, we receive selected 113 patients who were biopsy-proven colorectal cancer from June 2019 to May 2020. And these patients were selected on the exclusion criteria of age. The exclusion criteria was age less than 15 years and age more than 65 years. And the other exclusion criteria was any other cancer except the colorectal cancer. The patients were admitted in the ward, and 18 points of questionnaire was given to the patient. Especially each question was asked separately from the patient. Either individually asked that the patient got delay on its own side or on the physician side, or the treatment delay was there. The results were, out of these 113 patients, the 65.5% of the patients were male and 35.5% were female. The 82% of the patients out of these 113 patients were presented delayed, either any of the end. And 17% of the patients were only those who presented within 3 months from onset of the symptoms. The most common cancer we received in the delayed phase, like 82% of the patient, 44% patients were stage 3 at the time of presentation to our ward, and 39%, approximately 39% of the patients were at stage 4. These are some of the charts. As you can see, the most common tumor was rectum. 65.5% of the patients having a rectal cancer, while 18.6% were patients were having a rectosigmoid cancer. The least common site was transverse colon. Out of this, the patient presented 44% was stage 3 and 39% was stage 4. The most common symptom of this 113 patient was bleeding PR, followed by constipation and abdominal pain. The fecal incontinence were not common in the patient except for the rectal cancer. 4.3% of the patients having fecal incontinence at the time of presentation with rectal cancer, while 18.9% with rectosigmoid cancer that was extending up to the rectum also have fecal incontinence. While the perianal pain was only common in rectosigmoid and rectal cancer, that is 9.5%. This study concludes that there is a need of central cancer data registry, especially related to the colorectal cancer, so that we can improve the survival and the treatment of these patients. The demographic study shows that the low socioeconomic group is more involved because of the lack of knowledge. They don't visit any physician even,
And at the side of the physician they visit usually also lack of knowledge regarding the CRC symptoms. The fearsome consequences of this diagnostic delay is the presentation is at an aggressive state, so much so that sometimes we are unable to do anything except for the divergent stomas. Regarding the prevalence of these symptoms among CRC patients in our study, the most common symptom was bleeding per rectum, and the light on the staging, if we can say that the 2/3 of our study was falling in the stage 3 and stage 4 cancers. This study revealed that CRC patients in Pakistan are facing delays in the presentation and diagnosis. The reason behind the diagnosis at the advanced stage with a poor prognosis. There are some few recommendations from my side, being a colorectal interest in colorectal surgery. Our healthcare system must launch a CRC screening program and its prevention on a national level to improve the healthcare related with CRC with key factor early diagnosis and management. The social and mainstream media and awareness program at the social level can be used to enhance the cognizance of CRC among the general population. The general physician should be aware of the burden of disease produced by CRC, and seminars should be conducted to teach the general physician for keeping a low threshold when a patient comes to a doctor with suspicious symptoms. Thank you.
Rabab, I would want to say something about it gives your presentation gives the impression that the doctors, especially general practitioners, are not aware of the disease. You see, in our society, if you are working in a field, you can observe that most of the patients, they start treating themselves initially. Then they want to go to the Hakims. Yeah. Then they want to go to someone who gives some wazifa. And then they come to the doctor. And I think the contribution of the doctors in making this delay is very less as compared to the awareness in the public and taking the shortcuts. I agreed with your recommendation that in the country level, we have to create an awareness program. But this awareness program should be on top. Because whenever you are not making the public aware of this problem, you see, public feels shy to share that he is having per-rectal bleeding. Yeah. I have seen hemorrhoids, they keep them for many years. They don't want to take any medical advice. So the awareness is very important, and we should not directly, I think, blame the doctors only. This is the society, and definitely the doctors are the part of the society. They may make this thing more complex.
I just want to add something in this. My study also conclude that the delay is on the both sides, on the patient side as well as on the physician side. Because almost equal percentage of the patient out of these 113 patients, the patient himself or herself tell that they went to a physician nearby their home or some thing like this, but the physician diagnosed them as something like hemorrhoid or fistula. Even some of the patients were even biopsied. But
for the biopsy, we are talking about the high things here. It is very prevailing in the society that when you are taking a biopsy, it will the tumor become aggressive, and the people, majority of the people are unaware of it. That without biopsy we can't do anything, and they blame the biopsy. Sir, please.
Okay, thank you very much actually, and especially Dr. Azhar Alam from Lahore, the original work done, and Dr. Hina and our colleague standing here. I just want to share with you a happy news. The good news is that now we are seeing T1 and T2s. There was a time, 2005, we have only one tumor board, general. Now we have site-specific 77 boards per month in our institute. And Professor Haris will vouch me. In Ziauddin also they have, and everywhere. So what we are now looking at is that what is the solution? Instead of making a list of problems, why don't we solve them? The solution is tumor boards. The more tumor boards we'll do, the more early tumors we will see. And this is the solution, like what you are highlighting a problem. So this is a problem. Now diagnosis is done. Yeah. Now we have to treat. Treatment is MDT tumor board. So our colleague Dr. Raza Sayed rightly pointed out the lower GIT MDT tumor board. So this is going to come up from this COLOCON. तो हमें ना मसले का हल निकालना है. तो मैं आपको ये खुशखबरी आपसे शेयर करना चाहता हूँ कि जब से ट्यूमर बोर्ड्स हमारे यहाँ हो गए, जैसे 2010 से हम संडे ट्यूमर बोर्ड कर रहे हैं, सिटी ट्यूमर बोर्ड जिसको हम कहते हैं, उसके बाद से अब हमने अर्ली डायग्नोसिस देखने शुरू कर दिए हैं और क्योर रेट भी बढ़ता चला जा रहा है. अभी छोटा सा काम ये करना है कि जैसे डॉक्टर अजहर आलम ने प्रेजेंट किया, अब बस इसको डॉक्यूमेंट करके, वो कहते हैं ना पब्लिश और पेरिश. अभी मेरे क्लास फेलो प्रोफेसर अमजद सिराज मेमन भी कह के गए हैं, डॉक्टर हारिस रशीद भी कह रहे हैं सब, कि जब तक हम पब्लिश नहीं करेंगे ना हमें ये इनकरेजमेंट ही नहीं मिलेगी. लेकिन मैं आपसे शेयर कर रहा हूँ बिकॉज वी हैव पब्लिश्ड मोर देन 28 manuscripts in peer-reviewed journal, and Pakistan is a country which has published more on MDT tumor board than any single country in the world. So we are proud of it. तो अल्लाह का शुक्र है कि उस पर आप थोड़ा सा पब्लिश करना शुरू करें. तो ये जो 5 पेपर्स हैं, अगर ये एक्सेस कर जाते हैं इंटरनेशनल जर्नल्स में, तो आप नेक्स्ट ईयर कोलोकॉन के अंदर इसको आप एनालिसिस करके देख लीजिएगा. आप मेरी बात को शेयर करेंगे कि देयर इज अ लॉट ऑफ ऑप्टिमिज्म, देयर लॉट ऑफ हैप्पी न्यूज़, एंड नाउ वी आर डायग्नोजिंग मोर कैंसर्स अर्ली एंड वी आर ट्रीटिंग देम सक्सेसफुली. ठीक है ना? तो ये कोई इतना मुश्किल नहीं है, बट बेटर देन व्हाट वी वर 10 years ago. And thanks to City Tumor Board Sunday morning when people come and sacrifice their Sunday and come and discuss. बढ़ता जा रहा है टाइम भी, केसेस भी. So it's a happy news. Thank you for giving me time to reflect on it. Thank you.
I want to recommend that whenever next time you conduct a conference on the colorectal, you should also involve the general public. You should allocate a session for the general public for awareness. Yes. It will create a good impact and you can get the low-grade tumor as well.
Thank you for the suggestion.
डॉक्टर अजहर आलम, आप थोड़ा कमेंट करेंगे कि आपने बहुत अच्छा डाटा प्रेजेंट किया. पब्लिक सेक्टर में इतना ज़्यादा काम करना आसान नहीं है, बहुत मुश्किल काम है. तो ये जो MDT आप कहते हैं, मतलब मैं आपको एज ए जूनियर मैं बात, आप एज ए सीनियर बात कर रहा हूँ कि वो MDT महीने में एक हो रही है. तो देखिए ज़्यादातर हमारा तजर्बा ये MDT डेवलपमेंट का, इस्टेब्लिशमेंट का, और मेरे कोलीग्स मुझसे मेरी बात को वाउच करेंगे, वो ये होता है कि हमेशा ना आदमी किसी और की तरफ देख रहा होता है और वो कहते हैं यार वो आते ही नहीं MDT के अंदर, हम तो इंतजार करते रहे. MDT जो डेवलप होती है वो हमने कुछ साइड इफेक्ट MDT के उसमें 1.5-2 साल तक हमने रेडियोलॉजिस्ट का इंतजार किया कि वो आ जाए, सिर्फ हम खुद जाके डिस्कस कर लेते थे. तो पीयर रिव्यू आपका अगर स्ट्रांग है, जो लग रहा है आपने जो प्रेजेंट किया अभी, और ये हमारी बच्चियों ने, डॉक्टर हिना ने प्रेजेंट किया, पीयर रिव्यू आपका जब इतना स्ट्रांग है, इंट्रा डिपार्टमेंटल यानी इंट्रा डिसिप्लिनरी, तो आप लोग इतने स्ट्रांग हैं माशाल्लाह. उसको मल्टी डिसिप्लिनरी में कन्वर्ट करने में मसला क्या होता है कि हर डिसिप्लिन दूसरे डिसिप्लिन का इंतजार कर रहा होता है कि ये कब आएगा, और बाद में वो एंड में वो यही प्रेजेंट कर रहे होते हैं कि जी हमने कहा था वो आए नहीं, हम तो इंतजार करते रहे. आप अपने तौर पे शुरू कर दें बस 2 डिसिप्लिन. मैंने किए हैं ऐसे बहुत से बोर्ड जिसमें हम विदाउट पैथोलॉजी कहाँ से लेकर आएंगे, आप इतने कम है हमारे यहाँ, वैसे शॉर्ट है. तो ये मेरा आपको रिक्वेस्ट होगी, बल्कि आप इसको जरा हाईलाइट करें. मैं ऐसे ही पूछता हूँ प्रोवोकेटिव क्वेश्चन, बिकॉज दीज कॉन्फ्रेंसेज आर फॉर कंट्रोवर्सीज, फॉर इंटेलेक्चुअल डिफरेंस ऑफ ओपिनियन. ये कोई ट्यूटोरियल क्लास से नहीं हो रही है, जैसे अब डॉक्टर अमजद ने प्रेजेंट किया है कंट्रोवर्शियल थिंग. दैट्स व्हाई वी आर हियर. तो आप हर हफ्ते क्यों नहीं करते हैं बोर्ड, जरा आप मुझे इसका जवाब दें. सॉरी, मुझे नहीं, मतलब
जी सर.
आई होप यू विल नॉट टेक इट पर्सनल.
सर थैंक यू सो मच. इट हैज़ ग्रेट इंसाइट. मतलब ये जो क्वेश्चन है इसके अंदर बहुत ज़बरदस्त बात है कि हम दूसरों की तरफ देखते रहते हैं. जब हमने 2017 में सर शुरू किया तो देयर वाज नो MDT एट द इंस्टीट्यूट लेवल. माई मेंटोर प्रोफेसर फारूक अफजल साहब ने स्टार्ट किया सबसे पहले, और हमने मतलब इसमें पर्सनल होके जो कम्युनिकेशन बैरियर थे उनको तोड़ा. जो ये चीज़ें थी कि जी उनको कहेंगे तो होगा, ये सारी चीज़ें हमने ओवरकम की और हमने इसको प्रैक्टिकली करके दिखाया कि चीज़ें पॉसिबल हैं. इवन देन बहुत सारी हर्डल्स होती हैं कि कम्युनिकेशन एरर्स आते हैं, बैरियर्स आते हैं, जी उसको कह दिया. तो हमने इन सारी चीज़ों को ओवरकम करके MDTs की हैं और इसके बहुत अच्छे रिजल्ट्स हैं. फिर देन कोविड आ गया इंस्टीट्यूट लेवल पे, उस तरह से फिजिकल पॉसिबल नहीं हुआ MDTs. देन हमने फिर उसको ऑनलाइन MDTs में कन्वर्ट किया. उसमें हमारे जो ऑन्कोलॉजिस्ट थे वो भी अनमोल से ऑनलाइन भी और फिजिकल भी मैनी टाइम्स आते थे, और ये चीज़ें बहुत अच्छे तरीके से होना शुरू होगी। लेकिन जो मैं आपको शेयर करना चाह रहा था कि हम उसको वीकली नहीं कर सके, दिस वाज हमारी डेफिशिएंसी थी। और ये जितना कि हमारे पास रेफरल है वहाँ पे और जितना पेशेंट का फ्लो है उतना हम उसको कर नहीं सके, ये हमारी मतलब कह लें कि वो डेफिशिएंसी रह गई।
रूम फॉर इम्प्रूवमेंट। आप उसको प्लीज वीकली करें, उसको पब्लिश करें। आपको शायद एहसास भी नहीं है कि आपका डिनोमिनेटर बहुत स्ट्रांग है। ये तो मुश्किल से कहीं मिलेगा आपको।
थैंक यू सर।
तो ये आप प्लीज इसको भी कर लें। डॉक्टर हिना से भी मेरी यही रिक्वेस्ट है, सब हमारे मेंटीज हैं तो कि हमारा टेफ बड़ा स्ट्रांगली काम कर रहा है। मेडिकल कॉलेज के स्टूडेंट्स ने बोर्ड्स इतने एस्टैब्लिश कर लिए जो सीनियर प्रोफेसर्स नहीं कर सके।
जी सर,
तो वी कैन हैव अ क्लैप फॉर देम अगर आप बुरा ना माने तो टेफ के लिए।
So, Dr. Nadeem,
आप इसमें करें। Thank you very much.
Dr. Nadeem, I have a comment and a question, suggestion for you. I am on. So, हमारा जो सबसे बड़ा problem है ना वो ये है कि at once we are practicing at a government hospital, तो जो हमारे provincial hospitals हैं और फेडरल हॉस्पिटल्स हैं वो एक पेज पे नहीं है। ये बहुत लंबी डिबेट है, आप भी इसको बहुत अच्छी तरह जानते हैं।
जी जी, मैंने पब्लिश भी किया है
जी। अब प्रॉब्लम क्या आता है कि देखिए हमारे जितने प्रोविंशियल हॉस्पिटल्स हैं पंजाब के, आप सबको आपसे ज्यादा मेरे ख्याल में आई थिंक हार्डली एनीवन वुड नो अबाउट देम। सो नॉट अ सिंगल हॉस्पिटल एट द प्रोविंशियल लेवल इन लाहौर, गुजरांवाला एंड ऑल दीज एडजॉइनिंग एरियाज, फैसलाबाद, सारे अस्पताल मिला के किसी एक के पास भी लिनेक नहीं है। ठीक है, अब जब लिनेक नहीं है तो वहां पे रेडिएशन का डिपार्टमेंट भी नहीं है। जिना में एक दो सीट्स खाली हैं, वहां कोई पोस्टेड नहीं है। मेयो हॉस्पिटल के अंदर ओल्ड स्कूल वही सेम मशीन्स मौजूद हैं, एक दो लोग पोस्टेड हैं एंड दे आर नॉट रियली वर्किंग। मेडिकल ऑन्कोलॉजी का डिपार्टमेंट, आई वर्क इन अ 1600 बेडेड हॉस्पिटल, सो वी डू नॉट हैव अ सिंगल क्लिनिकल ऑन्कोलॉजिस्ट विद अस। So I know these are the problems. मुझे हमें प्रॉब्लम से आगे निकल के सॉल्यूशंस पे जाना है। But at the same time, things, बहुत सारी चीजें हैं जो शायद मैं अपने लेवल पे चेंज कर पाऊँ, but things have to come from the top. So हम लोगों को इस कॉन्फ्रेंस को एक यूज करते हुए, एक टेम्पलेट बनाते हुए हायर अथॉरिटीज को इन्वॉल्व करना है, एंड वी हैव टू अप्राइज द इंपॉर्टेंस ऑफ गिविंग अ कॉम्प्रिहेंसिव केयर एट वन सेंटर। ठीक है, आई नो मैं अपने केसेस किस तरह से करता हूं कि मैं आई मीन ऑफ कोर्स हम लोग मंथली एमटीटी करते होंगे, बट मैं हर केस को पर्सनल लेवल पे डिस्कस करता हूं, उसके बगैर तो मैं मरीज को हाथ ही नहीं लगाता। सो दिस इज माय रूल ऑफ ट्रीटमेंट, बट अगेन दिस इज मी डूइंग इट, सो दिस हैज टू बी द इंस्टीट्यूट हु इज डूइंग इट। और वो किस तरह से होगा जब गवर्नमेंट्स इन्वॉल्व होंगी, तो हमें उनको इन्वॉल्व करना जरूरी है, ताकि मैं हूं ना हूं मेरा होना रेलिवेंट नहीं है, अगेन सिस्टम का होना रेलेवेंट है।
वैसे आप हो ना हो सकता है, गवर्नमेंट हो ना हो, वो भी चेंज होती रहती है।
जी, वो तो ऑफ कोर्स यही है, बट ये कि आई थिंक सिस्टम को बनाना चाहिए, उसके लिए आप
थैंक यू वेरी मच।
सॉरी टू इंटरप्ट, हम आपके साथ अभी खाने उस पे कर लेंगे इंशाल्लाह। डेडलाइन इज 3rd February, so we can conclude this debate.
Thank you so much. Thank you so much. We are short of time, so the panel of experts will now conclude this session.
Thank you very much, participant, especially the Dileep. I know him when he passed the FCPS and joined the Jinnah Medical and Dental College. He was very good in their surgeries, and hope for him to do well further. Otherwise, the other participant was also very good, especially those came from the Peshawar. He presented a very interesting thing. Rubab presented a commonest presentation here, and I would say thank you for all. Thank you very much.
Thank you, Dr. Sara.
Of all, I request panel of experts to please stay on stage.
I congratulate the COLOCON ward for conducting such a successful conference. Congratulations.
We would request panel of experts to please stay on stage to receive their certificate of participation. We would like to call Professor Haris Rashid to come on stage and distribute certificate of participation among panelists and speakers of this session. Professor Hussain Mehdi, sir, please move forward to receive your certificate. Professor S.M. Abbas, sir, please accept your certificate. Professor Abdullah Muttaqi, and Professor Tavish Chawla, sir, please come forward.
Now I would request the speakers to please come on the stage and receive your certificates. Dr. Riaz Ahmad, sir, please. Dr. Dileep and Dr. Rabbiya. Dr. Azhar for Dr. Awais. Dr. Abdul Rahman, sir, please. Dr. Rubab Nafis, ma'am, please move forward and receive your certificate. Dr. Hina Khan, ma'am, please.
Azam Ali, third year resident, who has worked with Dr. Dileep. Afira Bashir. Afira Bashir. Dr. Lashpat Rathore for presenting the surgical audit of colorectal ward. And now the moderator of this session, Dr. Sayyida Sara Kazmi. Thank you, Dr. Haris. We would like everyone to please stay seated for a few more minutes.
उकाबी रूह जब बेदार होती है जवानों में, उकाबी रूह जब बेदार होती है जवानों में, नजर आती है उनको अपनी मंजिल आसमानों में। नहीं तेरा नशे मन कसर सुल्तानी के गुंबज पर, तू शाही है बसेरा कर पहाड़ों की चट्टानों पर।
Ladies and gentlemen, giving away prizes is a source of applause and appreciation, rectitude and fortitude. It keeps morale high, the morale which can be held like Himalayas, the thinking power that expands like sea.
So, Colorectal Disease Patients Welfare Association and our organizing committee maintains such a tradition of giving prizes to those who participated in poster competition and scientific paper presentation today. Let's move towards the most awaited segment of the day.
For this exciting segment, we would request Honorable Founder of Colorectal Disease Patient Welfare Association, Meritorious Professor Amjad Siraj Memon, to grace us his presence.
Hold your breath. We are going to announce the winner of poster competition. So the gold medal and the first prize goes to Dr. Hina, poster number 6. Please give her a big hand applause.
Second prize, silver medal, is awarded to Dr. Sobia Hassan. Poster number 2. We are thankful to Mr. Mr. Majid Hussaini from Biophysique, Pakistan, for donating these gold medals for this occasion.
Now the third position in poster competition goes to Dr. Saja Riaz, poster number 12. And a special appreciation on poster competition goes to Dr. Hania Makbul, poster number 8. Please come forward.
And now for the best scientific paper presentation. And the gold medal for this goes to Dr. Dileep Kumar. And now, all the poster participants, please come on stage to receive your certificates. Dr. Mahnoor Hafiz. Dr. Naseem Ahmad. Dr. Aisha Rana. Dr. Tuba Umar. Dr. Kainat Mushtaba. Dr. Tairam Khalid. Dr. Sobia Hassan. Dr. Rubab Nafis.
Dr. Samra Jabbar. Dr. Riaz Ahmad. Dr. Razia Ramzan. Dr. Bushra Kiran Naeem. Dr. Madhiya Siraj. Dr. Amna Khatun. Dr. Murk Lakhani, Dr. Sahrish Ali, Dr. Manur Sadiq, Dr. Muhammad Saad Arshad, Dr. Abdullah Khalid,
Dr. M. Salim Sheikh, Mohammad Salim Sheikh. Dr. Hafiz Yahya Iftikhar. Dr. Hina Khalid. Mr. Izazullah. Mr. Ramesh Sumbul. Dr. Ayman Farooqi. Dr. Noman Ahmed Khan. Dr. Sarosh Ahmed Siddiqui. Dr. Saja Riaz. All of them have worked very hard for this poster competition. Please give them a huge round of applause.
Now I would like to thank our sponsors from pharmaceutical companies, Medtronic Company, Bosch Pharmaceuticals, I'll call upon their representatives to please move forward and receive your certificates. First Medtronic and then Bosch Pharma. Sami Pharma, representative from HiQ Pharmaceuticals, Ethicon, Biophysic Company, representative of Royal Medical, AGP Pharma, thank you everyone.
And now, it's time to cheer for our helping hands for organizing this entire event, without whose constant efforts and dedication, this event would not have been possible. So first, Dr. Lajpat Rathore.
It has taken months of constant efforts to make this possible for you.
Dr. Lashpat Rathod, everyone. Dr. Komal Fahim. Dr. Bushra Javed.
And the hostess of our today's program, Dr. Sabah Nazir. Dr. Ayman Farooqi, Dr. Aqil Azmi, Dr. Sayyid Abdul Rahman, Dr. Tairam Binte Khalid, Dr. Saja Riaz,
Dr. Sumaya Hafiz. Dr. Maruk Akhtar. Dr. Yahya Iftikhar. Dr. Junaid Khan. Dr. Ambar Ali. And our host for both days, Dr. Hussain Ahmad. Dr. Abir Khan. Dr. Hussain. Dr. Hussain Ahmad and Dr. Maliha Shabir. Dr. Sara Anis. Mr. Shakir. Mohammad Zishan. And Mr. Kashif. And now, we would like to give special token of appreciation to three very important persons who executed this entire event. First, Dr. Rabbiya Ali.
Please give her a big hand applaud.
And now, Assistant Professor of Colorectal Surgical Unit, Dr. Hina Khan. Consultant General Surgeon Dr. Rubab Nafis. Thank you so much everyone for putting up so many efforts. In the last, I would like to request Professor Amjad Siraj Memon to give some final remarks for this conference.
Assalamu alaikum again. I think the attendance at this occasion, when the conference is about to end, tells you that it has been a successful conference, and I hope to God that inshallah next year again we will bring more knowledge and education and training in various ways to our faculty members nationally and internationally. एक छोटा खिलौना होता है जो हमारे ज़माने में अब तो शायद नहीं होता होगा, जिसमें चाबी देते थे, फिर उसके व्हील को पकड़ना होता था, नहीं वरना तो वो मूव करता रहेगा. फिर वो जब आप बहुत ज़्यादा चाबी भर देते थे, फिर आप उसको रखते थे तो बहुत ही तेज़ी से वो गाड़ी चलती थी और फिर वो कंट्रोल में नहीं आती थी. मेरे ख्याल में दिस अप्लाइज टू रबिया. रबिया उस खिलौने की तरह है जिसकी चाबी जो है वो भर के हमने छोड़ दी है और वो चाबी बंद होने का नाम नहीं ले रही. शी वॉज ऑलवेज एक्टिव and the other persons, of course, I will have to mention is Dr. Mujib and Dr. Khurshid. इनकी आपको नज़र पूरी कॉन्फ्रेंस में ये दोनों नज़र नहीं आए, हर जगह मुझे खड़ा कर दिया, मुझे इज़्ज़त बख्शी, मैं बहुत शुक्रिया. लेकिन इसके आप उतने ही हकदार हैं, बल्कि मुझसे भी ज़्यादा हकदार हैं, क्योंकि आप अभी तक उस यूनिट को फरहान के साथ मिलके आप चला रहे हैं और माशाल्लाह यू आर डूइंग वेरी वेल. आई कीप गेटिंग रिपोर्ट्स, क्योंकि मैं जिस पोजीशन में मैं हूँ उधर रिपोर्ट्स बहुत आती हैं, कुछ कान भरे जाते हैं, कुछ शिकायतें की जाती हैं, तो पता चलता है कि ये बहुत ज़्यादा काम करते हैं, इनसे ज़्यादा काम ना लें. तो आई थैंक ऑल ऑफ यू, स्पेशली आवर pharmaceutical friends from the industry, from the suture divisions, from the endoscopy divisions, from the stapling devices वाला division, और स्पेशली बिलाल साहब जो है हमारे पूरे थिएटर के एडमिनिस्ट्रेशन चलाते हैं और इनको हमने जितना तंग किया है उसके लिए आई रियली आई एम वेरी ग्रेटफुल. I would like Dr. Mujib to come over now and offer the vote of thanks. Thank you very much. We'll see you next year.
Thank you very much, Professor Amjad Siraj. अब वक्त हुआ है उस चीज़ का जिसका सबको इंतज़ार है. उससे पहले दो चीज़ें अनाउंस करना चाहूँगा. एक तो हम ये आइडिया क्वाइन कर रहे हैं कि कोलोरेक्टल सर्जन सोसाइटी होनी चाहिए जो इसको बड़े पैमाने पे ले जाए. विल बी कॉन्टेक्टिंग ऑल दोज सर्जन्स हु हैव रजिस्टर्ड विद देयर ईमेल्स, ताकि उस पे हम क्वाइन करें और उस पे बैठ के डिस्कस करें. लेट्स एस्टेब्लिश दैट वन. एक दूसरा, आप सब लोगों का आने का शुक्रिया और इतनी देर तक इंतज़ार करने का शुक्रिया. और आखिर में जो कहते हैं कि जी देगियाँ खुल गई हैं, खाना खुल गया, तो लेट्स हैव अ लंच प्लीज़. थैंक यू वेरी मच.
It's a time of departure. We are keeping tremendous and marvelous views from all of you.